Hello. Good morning, ladies and gentlemen. Thank you very much for coming to Dublin for this session, and double thanks for coming to this particular session. Well done. Double achievement. Great. So I'll get started with the introductions, and maybe in the next couple of minutes people can, if somebody else wants to come and settle down. One thing is, you may or may, yep, please. Is this any better? Yes? Good. One thing that you may have noticed that in this conference, this is the only talk where we are actually talking about healthcare in general, apart from a fleeting reference to healthcare, some like couple of healthcare use cases in big data that have been referenced to in yesterday's keynote. So not a lot of coverage has been there from the healthcare. It was like sort of more of when I decided that okay, I want to talk on healthcare, I was sort of thinking that will there be enough interest in healthcare if that's the scenario. So thank you very much for the encouragement. Thank you for seeing that there is some interest in healthcare. Thank you. So a little bit about myself. I have been introduced into the world of big data in Yahoo. I was a senior product engineer in Yahoo, developing advertising products based out of London. And that's what caught my interest and the immense potential of big data. And from those days in Yahoo, I've worked in different industries and different companies, and some of the companies I've put up here. More recently, I'm actually, I provide my services under my own company called Optima Cloud Consulting, and at the moment I'm working in the financial sector with Barclays. So how come healthcare? So HealTrix is a startup that I started with a couple of other technologists and doctors, and more of something that came out of the discussion of, okay, we are doing so many things in big data. And also, even on the healthcare side, there are some of the use cases that you might have come across that are being spoken of. But what about the real challenges that we are facing today on a day-to-day life? Is there something that can be done? And that was the premise from where we started. And so let's look at how so far big data has been used in healthcare. So what was also actually referenced was genetic research. So right from the very early days of big data, genetic research has been one area where big data has been used in a big way. We have also seen more recently big data technologies, Hadoop, HBase, and these sort of like very fast storage and these sort of things being used in CRO, clinical research, pharmaceuticals, testing, post-market trials, and these sort of areas where companies are actually trying to gather like big, immense amounts of data and do analytics on like low-cost computing frameworks. What we have seen more recently is so if I go too fast and if I'm not giving you a good reason, please let me know. I have been told before that I sometimes tend to go too fast, so I'll try to slow down as far as I can. So this one here that we see is more of using big data to predict the onset of various illnesses, pandemic illnesses like the seasonal flu and these sort of things. And while this has been done before by, say, the NHS in the UK or the Department of Health in the US, if you see the last couple of years, there has been a trend that Google can actually predict things much faster than what the Department of Health can do. That is because they are doing social analytics, analytics of the social networks, and they are actually picking up information where people are actually talking about flu and illnesses, and from there they are able to identify that okay, these are the areas where flu is developing much faster than when Department of Health actually gets the data, assimilates it, creates a report and brings out. So these are the things that we have seen so far. But what about healthcare service delivery? So when I say healthcare service delivery, I mean the day-to-day life. So we fall ill, our family members fall ill, we go to the doctor. There are like a lot of long-term condition patients like diabetics and hypertensive patients who have to go regularly back to the doctor every now and then for their regular checkups. What about our challenges there? Is there something we can do there? This is not something that we hear very frequently as something that big data might help. And this is precisely the topic of this particular talk, where I would like to explore like what are the sort of challenges that we have, and whether we can actually do something with big data to reduce or eliminate some of these challenges. So let's look at the challenges that I'm talking about. When we talk about healthcare service delivery, so what we can basically divide the whole world into two parts. One is the area with low penetration of healthcare service, like I would say trained healthcare service providers, which is the area in red and yellow over here, and then the area with comparatively higher density of physicians or higher number of trained healthcare providers per 10,000 people. One thing you can actually see here, that the area of the low penetration, perhaps leaving out Australia, what we can say is this area of low physician density or low healthcare service penetration also is unsurprisingly the area with lower economic development. And you have the problems associated with that, like not a very well development transport infrastructure. So this is what we will look at first. So what are our challenges in healthcare delivery for the areas with lower density of trained medical professionals? So one thing that is associated, so I'll tell you a brief, a small story, which is my own personal story. It's my father was a doctor and I grew up in India. So I have lived in India for close to 20 years and lived in the UK for close to 10 years now. So I have seen like the challenges in both sides, because my father was a doctor and he came from a small village, but we were settled in a city. So we used to frequently go back and forth between the village and the city. So we have seen what happens there. So the fact is not just that there are less number of physicians in general in a country per say 10,000 people, but it's also the fact that the presence or the availability of these services are very much skewed. And while in the cities, some of the cities or some of the places are actually having as good healthcare service facilities today as we have in any other country in the world, while if you look at the villages, like there are maybe scores of villages in which you will find maybe a single trained medical professional who has a degree in medicine. So this is an even bigger challenge than the flagship figures that we see there. So there is immense skewness of the availability of healthcare services. Now, so this is I've taken just the summary from a report. So this was a report that was created highlighting the differences between the rural and urban healthcare services in India. This is published in the US National Institute of Health website. And this study was actually funded by the Bill and Melinda Gates Foundation. So a couple of things, interesting things to note here. So you have 70 out of 100 primary healthcare professionals without formal medical training in the rural setting. And you are 15 times more likely to come across an unqualified service provider than somebody with a medical degree in the rural setting. So you can see the gravity of the issue here. So what can we do? What can we do by bringing in technology here? We cannot get more doctors to the villages. That's not what technology can do. What we cannot do is we cannot overnight improve the transport facilities so that these people in the villages can come over to the cities to see the doctors. No, we cannot do that. But something that is also very coincidental with this particular map is that the mobile network penetration is very high in these areas compared to the landline infrastructure or the transport infrastructure. So what we can do is we can actually bring knowledge, we can reduce the skewness of knowledge of trained medical knowledge that is there in the cities between the city and the villages. So how can we do that? Let's look at this. So one of the ways we could do this is if we can actually create centers with the right infrastructure to gather this information. Like we don't need a trained medical service, medical professional to actually gather this information, because in today's world we actually have equipments which can actually do this. We have the right network infrastructure. All we need to do is, if we can get the right information collected at the point of service, and if we can bring that information over to where we have the availability of the medical services, then we can somewhat reduce the skewness of the knowledge. And this is where we can actually help by bringing in technology. And how big data technologies can help? Well, what we need, because of the scale of the problem, is we need scale, because we are talking about countries like in Africa, in India, which are hugely populous countries. So we need scale. These are not countries where people are actually able to, especially the rural people, are not able to spend a lot of money. We need low cost, stable, secure, and a solution that actually works. And that is where big data can actually help us. Let's look at the other side of the world. So the countries with higher penetration of medical professionals, these are the countries where we are living in: Ireland, UK, US, most of Europe, I think all of Europe probably. And so what are the challenges we are seeing here? So I mean, fortunately for the last 3 to 4 decades at least, we have got pretty good medical facilities in this part of the world, and we are actually seeing the benefits of that. I mean, thankfully, people in these parts of the world are now living for longer. The life expectancy is higher than many other parts of the world. Yes, we are living for longer in these parts of the world, but are we living any better? Are we really enjoying that additional lease of life that this healthcare, the improved healthcare services have given us? In many cases, we cannot undoubtedly say a yes to that question, because what we are seeing today is problems such as these. We have a rising old age population, so people are now enjoying a longer life. But, well, maybe some of us are actually responsible for this, is that the younger generation is not growing at that particular scale to support all of the old age people. So this again is a problem very much prominent in Japan, where the population is decreasing over the years, while the old age population is increasing. So the problem we are seeing is we have a reduced or a smaller number of working professionals or taxpayers who are having to support a rising number of old age people. So that's basically the bane of good healthcare, if we call it that. Along with that, what we are also seeing is the onset of a lot of the lifestyle diseases, as we call them: diabetes, hypertension, many of the respiratory diseases. And these diseases are now coming on, the onset is coming much before what we used to see them, say 20 or 30 years back. So if you look at the combination of this, like people are getting things like diabetes and hypertension earlier, but our life expectancy is growing faster. So basically, we are actually living for longer with these conditions. So this combination is actually creating a very unsustainable situation, especially in the current setup of the healthcare service delivery in these parts of the world, where much of the healthcare service is actually provided by the government, and this is putting severe pressure on the public finances, because we are paying through them through our taxes. So if you actually look at the gravity of this problem, especially in the urban areas. So again, this is a good contrast, that while the problem is more prominent in the rural areas in the other side of the world, here we see that in the urban areas, say for example in London, if you want to see a GP, a normal appointment will probably take you at least 2 to 3 weeks to see a doctor. And if you want to see a doctor a specific doctor that you want to see, then good luck if you even get an appointment in the next month or 2 months. So that's the gravity. I mean, because of the huge pressure of the population and the reducing public finances and the pressure on the doctors, it's becoming very difficult to actually provide an acceptable level of quality of healthcare. So how can we help here? Now, one of the things, so what we are very happy about is we are very happy to live for longer now. But on the other hand, the long-term conditions, especially, I mean, I'm particularly picking up long-term conditions because this is one of the areas that I have personally explored where I feel that we can actually make an impact. There could be other areas, but I'm picking up this area because that's what I have actually researched myself. So these long-term condition patients, in the current setup, especially in countries like UK and much of Europe, we consider that, okay, we have an illness. Now, it's the responsibility of the healthcare service provider to make us better. So we go to the doctor, and the doctor gives us medicine. They will basically spoon feed us whatever information is required. We come back, follow it. We get better, good. We don't get better, we go back. So this is the current situation. We don't want to take enough responsibility for our own well-being. Now, this is something that there is a current setup where we want this to change. That is, it's me. If I'm suffering from something, I should understand myself. I should understand the condition I'm suffering and take more responsibility for my well-being. And if I can do that, then number one, I stay better, I live better, I understand what's going on with me. And number two, I don't need to go back to the doctor that often. And what's even better, that I'll probably not need to go for an emergency treatment, or I'll probably not have a heart attack at least for the next few more years than otherwise. So this is something. So what, again, if you notice carefully, what we are saying is we want to move this concentration of the knowledge that is currently there with the healthcare service provider from the providers to the patient in a way that the patients can actually accept and use. So a knowledge transfer should happen that empowers the patients and enables them to take better care of themselves. So this knowledge transfer is something that we can use, we can actually help with technology. So actually, just a couple of slides later, I'll show you one of the case studies where we are trying to achieve this. And what we are looking to achieve is the patients are more confident of themselves, they are more aware. So if we have to go back less frequently to the healthcare service provider, we are reducing the pressure on them. And finally, so this is the last point is actually quite important from the point of view of the finances, because unplanned hospitalization or urgent treatment or emergency care is the most expensive part of the treatment. And it's not even the doctor's fees that are more expensive, it's the real estate in the emergency room that is far more expensive. And the expense is not just because of the amount of money we are spending, because once a person who is, say, having some sort of an issue but is in no danger of dying, occupies a bed in the emergency room, and the emergency room is now full, another person, even if that person is dying, will still not be able to get in because nobody can be thrown out of the emergency room unless a doctor has certified. So that is the price that we pay for unplanned hospitalization. So if we can reduce unplanned hospitalization, so then that's a big gain in terms of healthcare service delivery. So currently this is an area of focus for, so I currently live in London, and I'm more aware of the UK's national health services than the other countries. So this is currently a big topic of discussion within the NHS. How can we empower patients more so that they can take better care of themselves? So let me give you a very small introduction on HealTrix. I promise I'll not make it a marketing or a sales pitch, just a very strong, small introduction of why why HealTrix is even relevant here. So HealTrix is a very young startup. I mean, we started less than a year ago, maybe around 6 to 8 months ago. And we didn't want to start a company that is either an IoT company or a big data company or a telehealth company or a remote monitoring company. We wanted, because this company was created within the discussion between some software engineers and some doctors, we wanted to come with some solutions that we can actually provide to patients, end-to-end solutions that can make use of any of these technologies. But the idea is on creating an end-to-end solution. So our current focus is on diabetic and hypertensive patients. So we are trying to come up with a solution that we can actually give to diabetic and hypertensive patients to do exactly what I just told. But our focus is also on building a platform, building the technology that we can easily use for other type of diseases. So not just restrict ourselves to that. So and that is and demonstration of this is we are currently working with the NHS in one of the test-based innovation program called the Technology Integrated Health Management, and this. What we are doing here as part of that project, here we are involved with around 10 other software companies, not software companies, but 10 other companies. Some of these are device manufacturers, some of these provide different types of medical equipments or medical services. And we have Surrey and Border Trust and Surrey University. The idea is to come up with an innovative way to provide better care for dementia patients. Again, with the focus being to empower the patients themselves, or in the later stages of dementia, the carers, the informal carers, as the family members of the dementia patients, to take better care of themselves. So provide all of these infrastructure in a way so that they need not be completely reliant on the health services. So that's the focus of this particular project. This actually demonstrates the fact that the technology stack that we are using, we can actually easily port it to other types of diseases, even though our current focus is not dementia as a company's current strategy. But what we are going to show here is what we are currently doing in terms of the platform for the diabetic and hypertensive patients. Right. That's fine. So this is what we have. So what we have is we have this layer of that is the interface layer between the outside devices along with our mobile app. And the idea is that the mobile app will be used to collect data as well as send feedback to the patients, to the carers, or to the family members of the carers, to basically the bit that is in the hands of the people. And this interface also talks to other devices, fitness devices or other medical devices. As you can see, the devices have been purposefully chosen as home use devices that you can actually buy off Amazon and use. So these are not like sort of the devices that you will use in the hospitals. We have got already enough of solutions out there. The big players, Philips and GE, all have their ranges of solutions to take care of those. So what we are talking about are things that people can use without any sort of training or knowledge of medicine or healthcare, that they can just read the label on the back of the pack and can just use at home. So these are the devices that we are using to collect the medical devices. However, these are devices that we are also, the devices that we are talking about are actually certified by the European Union for use in medical scenario. So these are not just devices that have just come up yesterday and have maybe zero or next to nothing reliability. These are reliable medical devices. And then, so what we have here, so this is the interface that we have built in Spray. And then we are getting all of that data, all of these events, we are getting it into our central data bus, which is basically the main plumbing, that is plumbing all the various parts of the architecture, which is basically a Kafka cluster. And on top of that, we have got the business rules. So the idea is that the patient actually takes the readings or sends the readings from the devices that immediately goes into Kafka and gets processed by this rules engine, where we have got the rules. If there is something of concern, then immediately a feedback is sent back to the patient saying that, okay, there is something of concern, you should maybe go and check with your doctor. If everything is fine, then what we do is that we just store it in a data store. Now, what we have here is a Cassandra data store. This is something that we were actually, if you have gone through the initial introduction of this particular talk, then I mentioned about Hadoop. The thing is that this is something that we were exploring, that should we use HBase or Cassandra? A question that we had. And then what we found is that at this point of time, you can see there's a very simplistic, very simple architecture, and we don't see the need to actually bring in the complexity of the full Hadoop stack in here, which is why we have chosen those technologies which provide the equal level of fault tolerance, equal level of replication, and all of that. but without having the additional burden of having the whole of Hadoop stack until and unless we use them. And then we have the analytics engine here, which provides a dashboard. Now, this is the dashboard that is meant for the healthcare service providers. Now, this is the beauty of it, that whatever readings are being taken here are actually stored here and can actually be delivered to the healthcare service provider if needed. The healthcare service provider can put in their inputs, which will again make its way all the way back to the patients. So while we are actually working in a remote setting, what we are doing is there is a two-way communication between the healthcare service provider and the patients, but only where needed. So what we are trying to reduce here is trying to reduce the need for the patients to go back to the doctor when he probably doesn't need to. But at the same time, so just to give you an example, currently what happens is when a person has, say, diabetes, at least in the initial days, he will have to go back for a checkup maybe every 3 months. And then what happens is fine, like first 3 months, 6 months, 1 year, 2 year, fine. And then all of a sudden, on one particular day, the doctor will say that no, your condition is getting worse. It has got worse. We need to give you a different, more powerful medicine. But what usually happens is the condition doesn't get worse one fine day. The condition gets worse over a period of time. But we are not actually checking any in between these 3 months period. This period of 3 months have come from statistical studies over a large population saying that, yeah, 3 months is an ideal balance or maybe a compromise between not putting too much pressure on the doctors while also trying to catch this onset of diseases as early as we can. But do we really, this is where the technology can actually help. We can actually decouple these two things. We can actually get the best of both sides. So what we can do is instead of 3 months, we can actually capture these readings much more frequently because each of those readings need not go back to the doctor. So usually what happens in these simple cases, what the doctors will actually see is they will see whether there is an increasing trend, whether a specific value has breached a particular threshold. Now these are things that our rules engine can actually do. At least it can do an initial analysis, and if there is anything of concern, whether it's 3 weeks, 3 months, or 3 days, it can immediately send an alert to both the healthcare service provider and the patient saying that, look, something probably needs to be checked up. It may not be 3 months yet, but there is something to worry about. So this is one of the advantages that we can get while we are reducing the overall pressure on the healthcare services, but still we are actually able to detect these conditions earlier, and we can probably even intervene earlier. The healthcare services can probably intervene earlier and prevent many of the lapses which might actually need some emergency treatment. Actually, we have got a bit of time. So a small story, when we were doing this discussion, we were actually talking about COPD. So COPD is not something, COPD is the pulmonary disorder. So things like where you have breathing problem and some problem with the heart and lungs and these sort of issues. So when we were actually discussing with our doctor friends, we were saying that for COPD patients, like that's also a chronic condition that could be there for years or maybe tens of years. Again, in a similar way, people are asked to come back every now and then back to the doctor for a regular checkup. But a lot of the deaths that happen in COPD happen because of a rapid degradation of their condition. So if you are actually coming back to this is a much more pronounced example of what I was telling with regards to hypertension, that when you have a much worse condition, then those periods could actually be very vital. Because again, the condition doesn't just all of a sudden become bad. It's like, yeah, there are situations where that happens, but in most of the cases, what happens is when it becomes bad between those intervals when you go back to the doctor. So something like this can actually help reduce those intervals to a smaller, say, days, if not anything else. Because what happens for a COPD patient, all you need is an oximeter that you need to put it on your finger, and in less than a second, it will tell you the percentage of oxygen you have in your body. So is that good or bad? is there a trend? If you keep on taking that readings over a few days, it tells you whether there is a trend of decreasing oxygen level in your blood or not. So that's all that is needed. That's something you can do at home. It's just that that information is not yet out there in public. People are not used to these sort of things. So that is something that a solution like this can actually help. Now, now here comes the reasons for the choice of the technologies. So we are talking about our health. We don't want a system that might miss a few important bits. So what we are looking at when we actually chose this technology stack, we look for these qualities. We need our whole solution to have all of these qualities, and we can only have that if every bit, every part of the solution can actually have that. And that is what has been the main driver of each of the parts, each of the technologies that we have chosen here. So that's the only way we can say that a solution is truly scalable, fault tolerant. As interoperable is a big thing in healthcare nowadays, because we have got so many disparate systems. We need to have the ability to plug in and plug out, hook in and hook out of different systems. So interoperable and secure, obviously, because we are talking about healthcare data, which is in most of the countries classified as highly secure, highly like personal data. So most of these things I've already covered. So the gains that you get is people feel much better about themselves because they know exactly what's going on with themselves, and the rest of the things that we have covered before. So that's it. I mean, this is something that the reason I actually didn't want to cover anymore is that I wanted to get across this message that there are challenges that we are facing in our day-to-day life today now that we can actually address with a combination of these new technologies if we can focus them on where it matters most to our own lives, our families' lives. So we are trying to make a small impact through this company, but yeah, I mean, I would encourage people to think about it, and maybe there is a scope that others can actually come in and contribute as well. Thank you. Any questions? Thank you. Sure.
Have you got any kind of customers? What's the business model? I mean, it seems to me you have to collaborate with hospitals. Otherwise, how are you interacting with the patients?
Correct.
Can they subscribe to your service? Or?
Yeah. So the question is that for making use of this, we need to collaborate with hospitals or somebody. So how are we doing it? Because how are we getting access to the patients? Which is a good question, and which is what we are actually constantly working on. So, like I showed, we are actually engaging with NHS in ways to show them that this is something that a technology that they can use. But on the other hand, we are also working with the primary healthcare services, which is the GPs in the UK. We have started off with UK because that's where we are based currently, but we have plans to actually spread out to the rest of Europe to begin with. And so that's how we are actually getting to the patients in, and also we are actually looking at private healthcare. So especially in the big cities like London, Birmingham, Manchester, within UK, we have a sizable number of private healthcare services as well. So that's we are also trying to reach out to them.
Another question is about your architecture. Sorry.
Sure.
Have you considered using the stream analytics?
Stream analytics, good. So actually, if you would have looked at the description, you will see that I have spoken about NLP and certain analytics products. When I was actually creating this, I found that no, we cannot actually cover a lot. But it's a good point that analytics is something that can help us, but analytics can help us at a point when we have some data, some amount of data available on which we can actually do the analytics and get the results out of it. Which is why at this early stage, we are trying to keep things simple, provide the services at a simple stage. But once we actually get people using it, that's where we are, your point is spot on. So that's where we'll be looking at those things. So we have like plans, for example, integrating it with social media, getting people of similar long-term conditions speaking to each other, because there are different levels of knowledge among people. So that's one thing. Sure.
Your approach is it's really nice. I was wondering if you have already contacted. There are various projects in the European Commission which exactly looked at telemedicine and also specifically in the use of big data for supporting patient in a similar way also for epilepsy, for example, for predicting, telling the patient when he's going to have the epilepsy the next hour or not. I was wondering if you're connected to those activities.
No, no, we are not connected with that one. We are actually, the test-based program that we are doing is actually being funded by a European fund eventually, but that particular project we are not. I mean, I would be interested to know more about it maybe after that.
And then I was wondering if from data privacy point of view, and how are you dealing that?
Yeah. So the question is more. The question is about data privacy. So as I said, yes, healthcare data is it comes under the Data Privacy Act, and so the way we are actually dealing with is so in the architecture you would actually see that we have actually segregated the interface into a separate layer, and that layer is what provides the interoperability, the data privacy, and all the regulatory compliance. So to actually segregate the to ensure that we are able to focus on those bits. So that's how the architecture is.
So at the start we mentioned a lot about developing countries and the difficulty that they have with
Yeah.
healthcare. How would you see a system like that working in a developing country, maybe where resources can be used lavish?
Right. So the question is, how can we use a solution like this in the developing countries? Very good question. And given the fact that I come from India, that has always been in the back of our mind that we need to come up with something that we can roll out there. So first of all, I mean, if you think of it, what this particular system is doing really is you have the patients here and you have the doctors here, and they can be geographically located anywhere in the world. And that is how we can actually roll out this particular service in places like Africa and India, where healthcare service is very much skewed and geographically, like different places have different levels of service. And the point that I was stressing, that these are instruments which need no knowledge of healthcare or medicine. You just need to read the label and use it. These are meant for being used by common people. That is precisely the reason we are actually working with these sort of instruments, so that we can actually go on to that level. But from a pure business point of view, we are not yet at the stage where we have the capital or the and also being a London-based company, we cannot take that as our first step. That's a much more capital-intensive first step that would have been, which is why we are starting off with what we have at home, and then we'll look outwards.
One question here. This is a great idea, I think, but this rule engine here, how can you trust that one? I mean, what happens if the rule is missing or something goes wrong, or
Correct.
everything is fine?
Yeah. When we say so, the question is the rules engine here. How can we trust that this rules engine will work? Because this is a very given that this will be a critical part of the healthcare pathway, the treatment pathway. So the rules we are talking of here, or the rules that we are starting off with, are some very basic, simple rules. So rules like in the UK, we have got the NHS guidelines, which says that, okay, when you're taking your blood pressure, if the blood pressure is beyond a certain reading, say if it is beyond 140/90, then you are, then it's thought that, okay, it's concerning. So if a doctor actually sees that, he will say that, okay, come back next couple of days for more readings, because they don't take a decision on one data point. So and if there is a consistency in those readings, that the readings stay in top, then they consider like some sort of treatment. The initial treatment would be change of lifestyle and these sort of things. So these readings, so this is an advantage of NHS, that they have these things documented and well published guidelines that are used uniformly across the country. So to start off with, what we are doing is we are encapsulating those guidelines into here. So those are the simple guidelines that will go here. So some of the things will be like applicable to everybody, but with the also the feature that the doctor who is actually seeing them, the doctor can actually set a higher or lower guideline for a given patient. So that is where the personalization comes. So for a person who has got multiple health conditions, for him the thresholds might be different to a person who is perfectly normal and just taking the readings for monitoring purposes. So yeah, thank you. Okay, I think we are out of. We have about 30 seconds, maybe.
How are you planning to handle limited connectivity between your data center and the devices?
When you say limited connectivity, it's a limited network.
Yes, yeah.
Okay.
The data has to flow, and you basically don't see the data.
Right. So the app itself can actually store a certain amount of data till it goes online. So that feature is there within the app. But if it is like for months, then that'll be a problem. Okay, I'm actually available to take any more questions, but outside we'll have to vacate the room. So thank you again. Thank you very much for coming.